to come and give us this talk for the past few months, but we're quite lucky that she could make it today. She's quite involved in a lot of projects, one of them being the Flamingo project. And I've had the privilege to also work with her in global surgery. So today we'll be discussing the approach and management to an adrenal incidentaloma, and we're quite happy and excited to have discuss the topic with us. And we'll try and make it as interactive as possible, because she really deals with these tumors for quite commonly. So I'd really like to hear how our experience is and how we should be dealing with these cases as we see them quite often with our imaging and patients that are being staged for cancers. Professor Lydia, you can come to it. Thanks.
Thanks very much. Yeah. Oh, okay. Hey, good morning, everyone, and thanks very much. So I always have to stand on the side of the podium. Let's see, what have I done? Is it fine? Okay, good morning, everyone. Thanks very much, and thanks for the welcome. So it's great to be here, Sam. I'm not sure if it was me or you that we were struggling to get into this space, but it was at the right time. And I'm very happy to be talking about an academic topic in this meeting and something that crosses over between the two teams. So, John, just to give a sense of who's online with us from other parts of the country or the city, or.
Yes, thanks, Lydia. This might help if we put it just under your collar here. Yeah, so it's a collaborative teaching effort. It's regional, so we do have colleagues from other countries, but it's mainly the registrars and a few consultants from around the country. It's CPD accredited. We've been running it for a few years, and we found that it has really enhanced our ability to be involved with training, because the quality of the talks has improved quite substantially. So it's predominantly a collaborative training effort nationally.
Right. Thanks very much. Okay, so I'll see how this sounds. If I put it on. Okay, just tell me if you can't hear online. So when we talk about adrenal tumors, we're really discussing, it's not moving. So, yeah, there we go. Hey, every team's got to have someone like that. So when we operate on the adrenals, that little yellow box always there? Okay. So when we talk about when we decide to operate on the adrenal, there are really two reasons. We're either operating because of the adrenal resulting in hypertension. So if we remember the surgical causes of hypertension, 3 of the 5 of them were endocrine related. So patients who present with hypertension, who fall into the category of uncontrolled hypertension at a young age on multiple agents, and with any of the clinical features, you need to think about tumors in the adrenal gland. That's not something that you will commonly face as urologists, but it's the reason that we often operate on the adrenal. The other reason that we operate on the adrenal is because we find a mass in the adrenal, and that mass is either going to be an adrenal incidentaloma, which we'll talk about today, or an adrenocortical carcinoma. Adrenocortical carcinomas are extremely rare. They're the incidence is 1 in a million per year. They're extremely aggressive tumors, but I've probably seen in 10 years of endocrine surgery, 3 patients with adrenocortical carcinoma. So we're talking about a very, very, very rare tumor. However, adrenal incidentalomas are not rare. The first thing we need to know about them is what is the definition of an adrenal incidentaloma. So the adrenal gland, as you know, is pyramidal in shape. It's got a little hat and then 2 legs that come down, a medial and a lateral limb. And any mass that's more than 1 centimeter is defined as a tumor or growth in the adrenal. And that's important because sometimes the radiologist will say the adrenal gland is a little bit bulky, and your definition of bulky versus a lesion in the adrenal is quite important. So it's a 1 centimeter lesion that fits into the definition of an AI. The adrenal cannot be called an adrenal incidentaloma if it's functional. So what we mean by functional is that it's producing an excess of one of the hormones, catecholamines or cortisol or aldosterone. So it's got to be non-functional for it to be an AI. It can't be incidentaloma if you found it when screening for something. So a patient with von Hippel-Lindau or one of the other genetic syndromes. And it can't be when you do it as part of cancer staging. So if you have a patient that has a malignancy, an SCC or prostate or something else, and there's a mass in the adrenal, that's actually no longer an adrenal incidentaloma if you find it on staging. This has got a higher probability of being a MET. So it's a slightly different scenario, but it is one that kind of fits into this talk as well. So it's got to be incidental, truly incidental and non-functional. Okay. So how common are they? So in endocrine surgery, we deal with a lot of incidentalomas. Actually, one of the 50th students was teasing me the other day, and they're like, this is an incidentaloma finding about our exam. So we deal with a lot of incidentalomas, both in the thyroid and in the adrenal, and they're actually a public health problem because most of these patients are actually not at risk from any pathology from this lesion, but they get extensively worked up. And we spend a lot of health resources on this. So a rational approach is really important. On autopsy studies, about 2% prevalence. And then the prevalence on CT scan depends on age. So young patients under 30, you'll only have a 0.2% rate of an AI. But when you get to patients over the age of 70, and again, this is relevant in your context, where you have quite a lot of older patients, it's up to 10%. So up to 10% of CT scans that you do in patients over 70, you will find something in the adrenal gland. So the more and more we image, the more we find these tumors. Can you manage through that yellow box? Anyway, kind of, you're working on it. Okay, no problem. So what could it be? We've done a CT scan for renal stones, let's say, for example, pick up something in the adrenal gland. What's the differential diagnosis? What do you need to be thinking around? So I've summarized a couple of studies in this blue box, which is titled summary, because it collates the information that we know about the incidence of what these might be. And essentially 90% of these lesions will be benign. So the vast majority will be benign. And of the benign ones, the vast majority are non-functional. In other words, they're not producing any of the hormones related to hypertension. In other words, they're not significant. So 75% of all adrenal incidentalomas are non-functioning, benign adenomas, nothing to worry about. Then about 10% of them are cortisol secreting, either mild cortisol secreting or moderate or severe, resulting in Cushing syndrome. 5% of them are pheos, and that's the one you really don't want to miss. About 1% secrete aldosterone, if you remember, that's the Con syndrome. And then around about 10% of them are malignant. And that's divided into half of them being secondary, so metastases to the adrenal. The adrenal gland is extremely vascular, so it's a common site of METs for metastases. And about half of them are primary adrenocortical carcinomas. Now, when I look at this data, to me, it seems like a massive exaggeration of the malignant risk, actually, because we certainly don't see 1 in 20 of these lesions being adrenocortical carcinomas. So what skewed the data here is that these are from operative series. So these are only patients who've had an operation. And obviously, if they've had an operation, there was something worrying about that lesion. So you can say at least 90% of them are benign, probably more than 95% are benign in reality. Okay, so the subset where we need to intervene is quite small. This is just a recap of what the adrenal gland produces. There are actually 5 different types of hormones, but for our purposes, it's really the 3 that we need to worry about. And when you see the CT scan with something in the adrenal gland, you really need to ask yourself 2 questions. The first one, is this a functional tumor? And the second one, is this a cancer or not? And that's really what the workup is about. Okay. There are many, many guidelines on this. I recommend the European Society of Endocrinology Clinical Practice Guideline. It's quite rational and it takes an approach where we don't over-investigate. So let's talk about the first question. Is this a functional tumor? So I've had some calls before from members of your team. There's something in the adrenal. The first thing we really ask is, have you sent off the metanephrines? Okay. And that's because the exclusion of a pheochromocytoma really affects the rest of the patient's management. So the one thing you don't want to miss as you're planning an operation or a biopsy is that this lesion is a pheo, because that's potentially life-threatening. Because if you intervene surgically in a patient with an untreated pheo, they can have a pheo crisis on table. And as you know, you can get malignant hypertension and die from that. So the one test that we have to do for a functional assessment is to check for catecholamine excess. And the way that we do that is with a 24-hour urine collection. Because catecholamines fluctuate throughout the day, you have to have a 24-hour collection. It needs to go in an acidified bottle, but NHLS will know which bottle if you say catecholamines, and sometimes you have to go and pick it up. And the result of that takes between 3 and 6 weeks to get back. So it's really frustrating. It takes a long time. Sometimes if you really need it urgently, you can phone the Red Cross lab and they can try and speed it up for you. And with the result, you need to interpret it within the context of your patient. So an abnormal result that we would associate with a pheo needs to be 3 times normal, 3 to 4 times. You can very easily get catecholamines that are 1.5 times normal, 2 times normal, just from physiological stress. Patients been in a car accident, they've come in with pneumonia, they've just had an operation. All of those things will push your catecholamines up a little bit, up to two times normal, and that's not enough to make a diagnosis of a pheo. So it needs to be 3 to 4 times normal. And if your catecholamines are high or borderline, often we need to repeat it to confirm. But let's say you want to plan an operation for cancer and you've got a borderline result, you can put the patient on a low dose alpha blocker, which some of your patients are on, or many of them already, on a low dose alpha blocker, because that will assist with making the anesthetic safer. So sometimes we do that when we're not sure. The second functional assessment test we often do is a cortisol level. So there are a couple of ways to check the cortisol. I don't know if you've ever had much experience with doing this. You shouldn't really have to do it very often. You can refer to medical endocrine and they can help you with it. But essentially you can either do a 24-hour urine collection again, or you do a overnight dexamethasone suppression test where you give a low dose steroid at about 11 o'clock at night and check the cortisol in the morning. The cortisol should be low. If the cortisol is high, it means there's a cortisol secreting tumor in the system. The third and the fourth tests we don't routinely do for every adrenal lesion. So for aldosterone renin, which is to check for cons, we will only do if the patient is hypertensive. So if they're not hypertensive, you don't have to do that test. Remember, only 1% of them are Cons syndrome. And the sex hormones, the DHEAS, we only do if we're worried about an adrenocortical carcinoma. So essentially, you're going to be interacting with the catecholamines and the cortisol levels. And if you need to choose one and you only have time for one, go for the catecholamines, because that's more dangerous. Okay, so that's the functional assessment. Is this tumor functional or not? Now we need to talk about the malignance assessment. Is it a malignant tumor or not? And the first way that we assess these tumors is to look at size. So people always say these size cutoffs are strange because at some point a tumor was small, but that's why it's 2%, right? So all the lesions that are under 4%, if you have 4 centimeters, if you have something under 4 centimeters, there's about a 2% risk of malignancy. Remember, again, these are probably slightly overestimates, but 2% is what we go with. Between 4 and 6 centimeters, you've got about a 6% risk, and over 6 centimeters, a 25%. And this is where that size cutoff of 6 centimeters equals an operation comes from. So any tumor that is over 6 centimeters, we will plan surgery for, and we will remove except for 1 or 2 exceptional circumstances, which I'll tell you about now. So size is important, and that's the one factor. The second thing we look at is the CT imaging characteristics. So how many of you have ordered an adrenal protocol CT scan? Okay. So anyone want to tell me what it's about? Any ideas? No. Oh, sorry, you have to move to the mic. Okay, don't worry. So, the thing about an adrenal protocol CT that makes it difficult to get is that you need an uncontrasted scan. Okay, so most of the scans we do for cancer and other workup is got an arterial and a portovenous phase, right? So we very seldom do a truly uncontrasted scan and a delayed scan, and you need that for an adrenal protocol. And what they're looking at with the adrenal protocol CT scan is whether or not the tumor washes out contrast. And in order to calculate the washout, you need to have the portovenous phase, the delayed phase at 15 minutes, and the uncontrasted scan as well. Are we dealing with the yellow boxes? Cool. Okay, excellent. So the top two there are the things that you really need to think about with this. So the value of an uncontrasted scan is huge in this setting, because if on an uncontrasted scan, the adrenal lesion has a very low Hounsfield unit, less than 10. You know Hounsfield units, those little point values you have for the density of the tumor. If it's less than 10, it is very, very, very unlikely to be malignant. So there's almost 100% negative predictive value to that test. And in fact, you don't have to go further from the uncontrasted scan. If the radiologist is there at the time the scan is happening, they should actually stop the sequence then and say, that's it. This is not something to worry about. And the reason that the Hounsfield units are low is that it's just a fatty tumor. It's a lipid-rich adenoma. So minus 10, less than 10 Hounsfield unit is the key factor here on the uncontrasted scan. If it's not less than 10, then you can proceed and do the rest of the adrenal protocol, which is where you do the portovenous and the delayed phase, and then the radiologist will calculate what they call a washout. You've heard of this as well, right? If the washout is high, that's a good thing. If the washout is low, it's a bad thing. Quite difficult to remember. The way I remember it is that tumors are nasty and they hold on to everything. So they keep the contrast in, but if it all washes out like a nice flowing river, that's great. So a washout of over 60% is good in an absolute protocol. Sometimes you don't have the uncontrasted and they will do a relative adrenal protocol washout, in which case it's over 40%. This is not as reliable as the Hounsfield units on its own. So it's really additional information that you can get and glean from the CT imaging. There are a couple of other tests you can do, like MRI, you can do an FDG PET, and you can do an SUV ratio, which we don't actually do in practice. So we only use the contrasted and uncontrasted scan. Sometimes we've discussed doing an MRI, but we've never actually gone ahead and done it. By the time you get to that point, you're actually quite worried and you either want to follow up with another CT or operate. Okay. Any questions about the imaging? Okay. So we've talked about evaluating by size, evaluating by CT characteristics. What about a biopsy? So the adrenal gland, as you know, is anatomically in a very difficult position to biopsy. And that is the first problem. And the second problem is it's very vascular. So you can't do a core biopsy. You need to do an FNA usually. And the third problem is that the FNA often doesn't give you a helpful answer. So you can do a biopsy, but the sensitivity is very, very low. If you happen to get lucky and you do pick up some tumor cells, obviously the specificity is very, very high, but the yield is quite low. The only time we would recommend a biopsy is in the setting where there is a known malignancy. In other words, when you're doing a staging CT scan in cancer, you see something in the adrenal, it's not lipid rich, it's more than 4 centimeters, it can sometimes be smaller, but it's not lipid rich, it doesn't look like a benign fatty adenoma, then you can do a biopsy to prove malignancy. But again, only if it's going to change your management. So if the patient has other metastatic disease already, and you're not going to do anything further, there's no point in biopsying the adrenal. But if it's going to make the difference between a curative approach and a palliative approach, then there might be value in doing an FNA, with the caveat that you don't always get a good yield on those FNAs. Okay. So I've mentioned that we generally don't biopsy them. There is obviously the example are in malignancy, which is a special circumstance. So if you have a primary tumor somewhere, known primary tumor, and you find something in the adrenal gland, you've got a 70% chance that that lesion is a MET, if it looks not fatty on the CT scan. Okay, so in the context of cancer and something in the adrenal, metastasis is the top of your list. But it doesn't work the other way around. So if you have a CT scan, no known primary, you're doing it for renal stones, and you pick up an adrenal lesion, you don't then have to go and look for a primary. So it usually doesn't present as the first presentation of a malignancy. I don't know if I'm making sense. So sometimes you'll get this from oncology or other places saying, we found something in the adrenal. It could be from the thyroid, could be from, and you want to go through a whole unknown primary screen. It's not appropriate. It's very, very unusual for primaries to present first with a MET in the adrenal. It's usually a later stage presentation. So it's not valuable to go and hunt for a primary when you've got a lesion in the adrenal with no known primary. Okay. Second special circumstance is, what about if you have two masses, one in the left, one in the right? How are you going to decide what to do? And essentially there you will evaluate each one on its own merits. Oh, look, the left one is 2 centimeters, low Hounsfield units. It's a lipid adenoma. We're not going to do anything. But look, the right one is quite worrying. Okay. For any lesion in the adrenal, you will always do catecholamine. So you always do a functional assessment. But if they both look benign, you can leave it there, or one looks malignant, you go and operate just on the one. And the third category, that's a little bit of a special circumstance, especially for us, is the younger patient. So in practice, what's going to happen? You've done a CT scan or something else. You see something in the adrenal. Now, getting an adrenal protocol CT scan is going to take you what, like 3, 4, 5 months? I don't know who's booking scans at the moment, but there's usually quite a long wait. So most of the time I would say, that doesn't look too worrying. Let's just wait and do the adrenal protocol as a kind of interval scan. But in young patients, it's much more likely that this is a significant finding. Remember, it becomes very common in the elderly. So in younger patients, it's quite rare. So in this situation, I would actually push for a more urgent scan if the patients are under 40 to try and get that adrenal protocol done within the next 4 to 6 weeks rather than waiting for 6 months. Elderly patients, even if we'd have to do a risk benefit around whether to operate, so we wouldn't use the same rules. And then there's one histological subtype of adrenal lesion, which is a little bit unusual. It's called a myelolipoma. I don't know if any of you have come across that on some of the CT scans. So myelolipoma is different for 2 reasons. One, it's not homogeneous. It's quite heterogeneous. There's some more solid bits and some fatty bits. That makes it difficult for them to assess the Hounsfield units. That's the first thing. And secondly, they grow really big. So they often exceed the 6 centimeter rule, but they are very clearly benign. So the radiologist should be able to tell you, this is a myelolipoma, and you don't need to jump in and operate on them just because they're 7 centimeters in size. So the size just comes with a little bit of a caveat around this particular lesion. Okay, so we're coming towards integrating everything. So I've kind of presented the fact that most of these are fine. You don't need to do much about them. What happens if you leave lesions in the adrenal gland and you don't do anything? This is a longitudinal study. It's pooled of 26 studies altogether over a long follow-up period. And essentially, it's not a problem to leave them if they are benign. So if you have evaluated properly, there was no malignant transformation in any of these patients. And this was about 3,000 patients, which is a big series for the adrenals. A few of them grew a little bit, but not more than 1 to 2 centimeters. None of them became functional later on. So if the functional assessment was negative, it stayed negative. If you had borderline cortisol secretion, it didn't become Cushing's syndrome, it stayed borderline cortisol secretion. Why is that significant? Because it means that after your first evaluation, if they're non-functional and they're benign, you can discharge the patient. So we have a lot of patients in the system who are coming for follow-up CT scans, follow-up cortisol, follow-up metanephrines. It's not appropriate. Those patients can be discharged safely, and that's what this study supports. Okay, I'm going to skip over to, this is the last slide. think second last slide. So this is the protocol that we use for managing the adrenal. So if we start, it's different colors on mine, but never mind. If we start, that's fine. Is it? You are also important, the ones that are here. So if we start on the left-hand side there, so we found an incidentaloma. We asked the two questions. Is it functional? Is it malignant? Right? So if we on the left-hand side to ask, is it malignant? We did an uncontrasted CT scan. If it was an elderly patient, there was no panic. We could do the uncontrasted CT scan when available. If there were younger patients, we would try and get a more urgent scan. If the uncontrasted CT scan showed it was a lipid-rich adenoma, Hounsfield units less than 10, and the tumor was under 4 centimeters, you can discharge the patient if they're non-functional. So that's a discharge arm. If your CT scan is a bit indeterminate, like your washout is a little bit low, or the patient's got a 5 centimeter lesion, you can do one of 3 things. You can either, well, 2 things. You can either repeat image in 6 months' time, or you can operate. And that you need to make a call depending on the patient. If you're really worried, Hounsfield units are high, low washout, it looks vascular and nasty, and it's big, then you will operate on the patient. So that's on the, is this a cancer side of the slide. On the other side, now remember, all of these patients need to have a functional assessment, at least the 2, the catecholamines and the cortisol. So all of them get that, right? So you do your functional assessment, everything is negative, and that's going to be the case in 75 to 80% of patients. Everything is negative if it's non-functional and it's benign, the less than 4 centimeters, low Hounsfield units, lipid-rich adenoma, discharge, okay? If it's borderline functional, then you refer that to Ian Louis Ross, and he's going to help and sort out that strange borderline cortisol, the medical endocrine team, borderline cortisol problem. They will do confirmatory tests and follow up. If the patient has a functional tumor, in other words, diagnostic for Refio, diagnostic for Cushing's, diagnostic for Cons, then they get an operation. Okay. So then you end up in the middle with surgery. So in conclusion, adrenal incidentalomas are common, and the incidence is increasing because of increasing imaging. The vast majority of them are benign and non-functional and can be discharged. We need to investigate functionality and malignant risk, but we need to avoid unnecessary investigation and unnecessary follow-up. We should channel scarce resources towards evaluation of younger patients who've got worrying lesions, and we shouldn't hesitate to discharge if they're small and benign. Thank you. Okay, we'll take some questions.
I think you touched on a question that I was actually going to ask just a bit. Thank you. So you presented interesting sort of figures in the patients we see a lot in urology. You mentioned that over 70, they often have like 10% chance of finding in adrenal incidentaloma, which seems to be a rare entity, because you said if you're staging someone and you find a mess, it shouldn't really be an incidental adrenal incidentaloma. The question I have for you is, if you find a lipid-rich, less than 4 centimeter, adrenal mass, should we be doing functional studies on those? And the other question I have is, should we be using serum markers for looking for pheochromocytoma or not? Because we've had cases where we were rushed to do a case in the same week, and obviously, like you mentioned, we went to Red Cross, and interesting thing, we got them to measure these parameters looking for pheo and at Cushing's within a 12-hour period of urine collection. Is this something you guys ever consider doing if you need to do an urgent operation?
Thanks. With regards to the first question, so yes, even if it's lipid-rich and it's less than 4 centimeters, you still need to do at least the catecholamines. So sometimes you look at the patient, and this is not a Cushing's patient, and so we will occasionally leave out the cortisol, but it's mandatory to do catecholamines for every patient with an adrenal lesion over 1 centimeter. I think that that guideline will change over time because as the CT imaging gets better and better, FIOs have a particular look, and we would probably not have to do them for every single patient. But right now, adrenal lesion equals catecholamines. You're quite right to then raise the issue of the logistics of getting the catecholamine result, and we really struggle with this as well. So there's urine metanephrine and there's also plasma metanephrines. Plasma metanephrines are less specific, but they're very sensitive. So if your plasma metanephrine is low, you can happily go ahead and do whatever procedure you need to do. However, we don't have access to plasma metanephrines here at Groote Schuur. We've tried to get it, and it's quite complex, and they need to batch them, and it's expensive, and it's been hard to do. So we stuck with the urine metanephrines. And there, essentially, it takes a long time because it goes to a different lab and it's batched. So if we want it really quickly, we either will call the lab ourselves or we'll ask the medical endocrine team. Joel is usually quite good with that, Joel Dave, to help us to try and get a faster result. I don't think we've had a 12-hour turnaround, so that's pretty impressive. But essentially, it's about the logistics of doing the test and how often they use the assays to do it. Rather than it actually takes a long time to process in the lab, if you understand what I'm saying. So plasma metanephrines would be a really good addition to what we can do because it will help us to move patients through the system, but it's quite difficult to get.
Thanks, Lydia. Such a helpful, clear talk. Just two quick questions. I think you've answered the first one. We do have those odd patients who've got less than 4 centimeters, non-functional, but lipid poor. And I think you answered that you would use washouts, and you might, in fact, repeat imaging if required. And the second question is, Bob Bagri and Eugenio Paneri pioneered laparoscopic transperitoneal, I think, adrenalectomy. Is that something that the robot, the Da Vinci robot, has a role, do you think?
So yes, the first question, if you're in that gray zone on your CT imaging, so it's heterogeneous or it's vascular and you're worried, even though it's less than 4 centimeters, usually we will end up doing repeat imaging. And we'll do that at 6 months, and then at 1 year, and then another year, and then discharge the patients. There are a few people in the system who've been followed up for a very, very, very long time. So sometimes we'll look at the scan and this just looks nasty. It looks invasive. It's touching a few other things. But I have not yet seen an adrenal cortical carcinoma that's small. They present as these massive, horrible tumors. They're often irresectable and they're rapidly growing, so over months. And that's the true adrenal cortical carcinoma situation. So yes, a repeat CT scan is the most pragmatic thing, and we usually do that. So yes, we do about half of our adrenalectomies laparoscopically. Transperitoneal approach, we don't use the retroperitoneal approach, and it's really about size. So we will hesitate to do something over 6 centimeters, sometimes 6 to 8. We can still have a discussion about doing it laparoscopically. Once it gets bigger than that, or it's malignant, we will always do an open operation. We do it transperitoneally because that's the laparoscopic approach that we're used to as general surgeons, and it has got some advantages, but there are also advantages to the retroperitoneal approach. And Ilna Conradi at Tygerberg does the retroperitoneal approach. So it's quite nice because in the city, we have both options available to us. Retroperitoneal, the one big issue is the patient has to be prone, and they often have to be prone for quite a long time. And we try to do a Cushing syndrome patient like that, and being prone for a long time when you have Cushing's is quite problematic. So it looks amazing and it works very well for the smaller lesions like the FIOs or the cons, but it's tricky in Cushing's. And nice to have both options though. Is this something that we should do on the robot? I think so. I'm just waiting for all the hernias and the low rectals and all the urology team to be settled and to be trained up and happy, because ours is quite low volume. But I do think that, I mean, if you see a laparoscopic adrenalectomy, especially on the left, you know, you're going through a lot of tissue all the way to the back. It's quite tricky and fiddly. On the right-hand side, you're needing to lift up the liver for the whole operation and get right underneath. The little vein is short and fat going straight into the IVC. So I think it's very, in other words, it's an awkward and difficult operation, And I think it could be improved by doing it robotically. So you must give us some space and we'll come and do it.
Well, I do the kidneys and see that real beautifully when we do kidney robotically. And you get that better access to the vessels. A lot more part of the section.
Yeah.
So we have to fill that all the time. We do it all the time.
Oh, I must come and join you and have a look. Just on the way. Yeah.
Thank you, Prof, for excellent talk. Prof, I just want to know, in terms of the metastases to adrenal, are they all functional? Do you have a percentage that are sort of just, and that's the first part, sorry. And the second part is often when we pick up an adrenal incidentaloma, we do our functional tests. We get requested to do our urine metanephrines. We do anatomical tests, CT scan. But prior to even having those functional results, we requested to do a maybe functional imaging as well, sister, maybe GE scan. Yeah. So is there like a percentage of catecholamines which will be sort of biochemically borderline, but will only be picked up on a scan, or should we first wait for those results?
Yeah, no, thank you for that. So with regards to the first one, the metastases are usually not functional. So it's almost like you're going to have one of the two problems. You're either going to have a cancer problem, met or primary, or you're going to have a functional problem. So the mets are usually non-functional. Having said that, the adrenocortical carcinoma can sometimes secrete different lines of hormones. So you can get catecholamines and cortisol up with an adrenocortical and the sex hormones as well. So you get virilization with the adrenocortical carcinoma. So, but those are very, very rare. Essentially, most malignancies are non-functional in the adrenal. Then in terms of the functional workup, so I would wait for the metanephrines before doing the MIBG, or we're now using DOTA scans. So if the metanephrines are low normal, you're not going to pick up something on the MIBG. And if you do, it's not going to be significant enough to operate on the patient. So it's all about the biochemistry first. Once you've got the biochemistry, you can try and localize better or look for mets. We mainly do the DOTA scan to look for bilateral disease in POs or to look for undiagnosed mets. Okay. Okay. Thank you.
It doesn't look like there's any more questions, but would like to thank Professor Cairncross for an excellent talk this morning. And would like to also congratulate her on a recent appointment as the head of Department of Surgery. We wish her well and all the best in her term. Thank you.